Okay, thank you very much, Scott. Okay, so we have one more session. This is going to be a board simulation session, mainly on infectious diseases topics. And we will be done by hopefully 6:30 if we move. Okay, so 2 days before delivering a term infant, the 20-year-old mother develops chickenpox. Of the following, the most appropriate plan of action is to separate mom and baby for 21 days, administer VZIG to mom, administer VZIG to the infant at birth, administer VZIG to both mom and the infant at birth, or administer VZIG to the baby only if the infant develops varicella. Okay, so administer VZIG to the baby at birth. That is the right answer. So C is the right answer. So why is that the right answer? So VZIG is approved by the FDA as VARIZIG. If it is for whatever reason not available, you can use IVIG. And this is immune globulin that is used to prevent or modify varicella in those who are susceptible, and it is indicated only for people who are at risk for having severe varicella infection. And you need to administer this as soon as possible, but generally within 10 days of exposure. So who is at risk for having severe chickenpox? There's only a few hosts. So neonates born to moms who have chickenpox 5 days before to 2 days after delivery. And that rule stands because that is the time when the baby acquires the virus transplacentally without having the benefit of protective maternal antibody. So that is a very high-risk situation. 5 days before delivery to 2 days after delivery means baby was exposed to viremia without the benefit of protective maternal antibody. So those babies are at high risk for mortality if they get chickenpox. So that's why we give them VZIG to try to prevent them from getting chickenpox. Immunocompromised individuals also, if they get chickenpox, they have high morbidity and mortality. So when they are exposed and known to be susceptible, they should get VZIG as well. And then hospitalized preemies and pregnant moms as well. Acyclovir is used to treat chickenpox in immunocompromised and occasionally in normal children. Its use in prophylaxis is controversial, so you will not be asked about this on the boards. It's generally not recommended for immunocompetent individuals as use prophylactically. It can be used for susceptible immunocompromised children, especially when VZIG or IVIG is not available, and you would also think about using it if active or passive prophylaxis cannot be given. And remember, for susceptible individuals who are exposed to chickenpox, if they don't have any contraindications to vaccine, you can just give them varicella vaccine, which will prevent them from getting chickenpox. And it needs to be given within 72 hours. All right, question 2 is an 8-year-old boy who has had no previous immunizations, who sustains a puncture wound to the foot. What's the best tetanus post-exposure prophylactic regimen for this child? Tdap vaccine and tetanus immune globulin, Tdap vaccine and tetanus immune globulin, TD vaccine and tetanus immune globulin, or tetanus immune globulin only. So this is a post-exposure tetanus wound prophylaxis, which is very important to know. Okay, so the right answer is C, Tdap and TIG, and so you need to know this table really well. What you really need to know is the number of previous tetanus toxoid doses the child has received and whether it is a clean minor wound or a dirty wound, okay? So if the child has unknown or less than 3, then that brings you in the category where if it is a puncture wound like this child has, then the child definitely needs a tetanus-containing vaccine, and which one you give depends on the age of the child. 7 years and older, they get Tdap. If they've already had a Tdap, they get TD. And then tetanus immune globulin, less than 3, yes. If they've had 3 or more, you don't need to give tetanus immune globulin. You just need to give a booster dose if it's been more than 5 years since the last dose. And with a very clean minor wound, which they won't likely give you on the board, it's almost always going to be a dirty wound, then you wait 10 years before giving them the tetanus booster, okay? So you need to know this table. So tetanus vaccine is a toxoid vaccine. That's a kill toxin. It's very effective when given every 10 years. Natural disease does not confer immunity so that you can get tetanus more than once if you have to be really unlucky. If pertussis vaccine is contraindicated and the patient is less than 7, then you actually give big D, big T vaccine. And 7 years and older, you give Tdap unless they've already had a Tdap, in which case you just give TD. And the only contraindication to tetanus vaccine is an immediate severe or life-threatening infection. Which of the following persons who has never received Hep A vaccine should not be vaccinated with Hep A vaccine? A 4-month-old boy with biliary atresia, 3-year-old girl traveling with her family to Central America, a 2-year-old girl with chronic Hep B, an adolescent engaging in high-risk behavior, or a healthy 12-month-old. Whoa. What happened? Thank you. Okay. So most of you figured out that a 4-month-old should not get hepatitis A vaccine. So the indications are to give Hep A vaccine to any traveler to areas where Hep A is endemic, which is in most of the world, excluding Canada, Western Europe, New Zealand, Australia, and Japan. And remember that you may also need to give immune globulin if travel is imminent within 2 weeks of vaccination, or if the vaccine is not indicated, such as in less than 1 year old. All children should receive vaccine at 1 year of age, and children not immunized by 2 years should be caught up. And states who already have immunization programs for 2 to 18 years should expand those to include children 1 to 2 years. So the indications for Hep A vaccine: patients with chronic liver disease, including those waiting liver transplant, anyone engaging in high-risk situations, occupational risk, clotting factor disorders, and outbreak situations. More vaccine questions. We're going to exhaust every vaccine known. So a 5-year-old boy, previously unimmunized boy, presents with sudden onset of fever, sore throat, and drooling. And I'll show you the radiograph. A vaccine with which of the following features would have likely prevented this infection? A live virus vaccine, a capsular polysaccharide protein conjugate vaccine, a toxoid vaccine, or an inactivated virus vaccine. And that's the radiograph. Can focus right here. So what is that? We rarely see that today. That's the thumb sign of epiglottitis. So what's the most common cause of, or what used to be the most common cause of epiglottitis? Hib, right, H-flu vaccine. So a vaccine, a Hib vaccine would have likely prevented this, and Hib vaccines are capsular polysaccharide protein conjugate vaccines. You guys did a good job with that. So it's important to know the differences between polysaccharides and conjugate vaccines. Remember that T-cell dependency is true of conjugate vaccines, not of polysaccharides. Conjugate vaccine elicits strong B-cell responses. They do have memory responses, booster responses, and they elicit IgG1 and IgG3, which form in the first year of life. And that's why we use conjugate vaccines in the first year of life, whereas polysaccharide vaccines are not immunogenic in children less than 2 years for all these reasons. Which is a true statement regarding the currently available meningococcal vaccines? They're routinely recommended for all infants in the U.S. They're live attenuated vaccines. They can be administered to asplenic children in infancy. They can replace post-exposure chemoprophylaxis with rifampin, or they're preferred, or the polysaccharide vaccines are preferred over conjugate vaccines. Okay, you guys are doing well. They can be administered to asplenic children in infancy. So let's review meningococcal vaccines. There are 4 conjugate vaccines available against serotypes A, C, Y, and W135. Actually, 3 of these are conjugated vaccines. One of them is a polysaccharide vaccine, which we rarely use today. So of the 3 polysaccharide conjugated vaccines, the ones that we commonly use are Menactra, Menveo, and Menhibrix. And I'm just going to use trade names just because it's much easier to keep them straight. Generally speaking, conjugate vaccines are preferred over polysaccharide vaccines. Menactra is again quadrivalent. It's conjugated to diphtheria toxoid, and it's approved for individuals 9 months through 55 years of age. Menveo is also a quadrivalent vaccine, and it is approved down to 2 months of age. And then Menhibrix is a bivalent vaccine effective against serogroups C and Y. This is not a travel vaccine because it does not contain protection against serogroup A, which is associated with travel. And this is given in a 4-dose series. So as you know, MMCV4, the conjugate vaccines, are recommended routinely for adolescents with the first dose at 11 to 12 years of age and a routine booster at 16 years of age. If someone's vaccinated between 13 and 15 years, they should receive a one-time booster between 16 through 18. You don't need a booster dose if the first dose is given between 16 and 21 years to a healthy adolescent. And you don't need a booster beyond 22 years of age. Do you guys know why the tops of my slide are being cut off? Anyways, okay, so meningococcal high-risk groups, certainly persistent complement component deficiency, functional anatomic asplenia also, travelers to where meningococcus is endemic, and research laboratory personnel. These are high-risk groups for meningococcal disease. There is also a new serogroup B meningococcal vaccine, which is relatively new. It was approved in 2015, I believe. So these are probably not going to show up on your boards, but just realize that 2 vaccines have recently been approved, and they're recommended only for high-risk individuals between 10 and 25 years of age. And they can be given either in a 3-dose or a 2-dose schedule, depending which type you use. And they are recommended routinely only for children 10 years and older with the risk factors that I just talked about. There is no routine recommendation for others, but it is wise to talk about these and at least offer them to adolescents who are going to be going to college. These 2 vaccines are not interchangeable. Once you start using one of them, you have to complete the series with the same vaccine. All right, let's not do IRS here. Let's just shout out the answers. This is a matching exercise. So we're going to match the clinical scenario with the virus. So a 17-year-old who develops a confluent rash during inadvertent treatment with ampicillin is most likely to have which of these viruses? Okay, C, Epstein-Barr. So this is infectious mono. About 90% of children who have infectious mono will develop a rash like this if you treat them with amoxicillin. And sometimes that can be used diagnostically. What about a school-age child with a lacy reticular rash on the extremities? What's the virus? A, parvovirus, B19. Okay, this is fifth disease, which you'll hear about later on. What about an adolescent who has post-auricular and occipital adenopathy, low-grade fever, and a discrete maculopapular rash beginning on the face? This one's a little harder, huh? Rubella. Okay, so yeah, those buzzwords, post-auricular and occipital adenopathy, if you see those words in a discrete maculopapular rash, that's rubella. Okay? Whoops, skipped one. An infant with a maculopapular rash following 3 to 5 days of high fever. Okay, that's roseola, which is caused by human herpes virus number 6. You just need to remember the buzzwords here. So what about a croup-like cough, high fever, and a confluent maculopapular rash? Yeah, that's measles. Okay, remember the 3 C's: cough, coryza, conjunctivitis, high fevers, and confluent rash. That's going to be measles. I am not able to advance this. All right. These are what? Koplik spots. Okay, bluish, whitish areas on red base on the buccal mucosa. Those are pathognomonic for measles. The problem is well, I'm not going to tell you because we have a question about that coming up. But this is also a question, a picture of a child with measles. All right, next question. A previously healthy 6-year-old has a 2-week history of cough, mild sore throat, and low-grade fever. He's not toxic, normal respiratory rate, and normal oxygen saturation. He has diffuse bronchi bilaterally, and he has a white count of 6.8 with 40% neutrophils and 50% lymphocytes. Chest X-ray shows bibasilar diffuse infiltrates. What's the most likely bug? Pneumococcus, Strep pyogenes, EBV, Staph aureus, or Mycoplasma? So 6-year-old who basically has a pneumonia. Displaying the odds, what's most likely? Okay, Mycoplasma, very good. This is a very good description of a Mycoplasma. This is the most common single cause of pneumonia in a school-age child. They can often have pharyngitis in conjunction with it, so they may complain of sore throat. Cough is a prominent feature. They may have croup, erythema multiforme, otitis media. These are all associated findings. And neurologic findings usually are post-infectious. They can also have an aseptic meningitis, Guillain-Barré, and transverse myelitis. 5-week-old infant presents with a 5-day history of tachypnea and a dry cough. The mother notes that the infant had drainage from both eyes 2 weeks prior to the presentation. On exam, the baby's afebrile, not toxic, but mildly tachypnic and has rales on exam. And the chest X-ray shows hyperexpanded lungs with bilateral interstitial infiltrates. These are classic scenarios. So what's the most likely bug here? Group B strep, Chlamydia trachomatis, Staph aureus, Strep pneumoniae, or Chlamydophila pneumonia? So a 5-week-old, I gave you the clue, the baby had some conjunctivitis, rales. Okay. Some of you got confused between Chlamydia trachomatis and Chlamydophila pneumonia. Remember, this is going to be acquired at delivery from mom. So it's going to be Chlamydia trachomatis, whereas Chlamydophila pneumonia is a cause of atypical pneumonia in school age and older children. Okay? So Chlamydia trachomatis pneumonia develops in about 10 to 20% of babies born to women with chlamydia. 30 to 50% are going to have a history of conjunctivitis, and that's the clue to the diagnosis. This presents between 3 weeks and 12 weeks of age, usually insidiously. Persistent cough, tachypnea, and rales are common. No fever. This is one of the causes of the afebrile pneumonia syndrome in young infants. If you do a CBC, they may have a peripheral eosinophilia. The chest x-ray is nonspecific, and you have to treat these babies with oral erythromycin for 2 weeks. 1-year-old healthy boy presents with a 6-day history of fever and swelling on the right side of the neck, and he has an erythematous, tender 4 by 4 centimeter fluctuant lymph node at the angle of the mandible. The rest of the exam is normal. What's the most likely bug? Group A strep, Mycobacterium avium complex, Bartonella henselae, Staph aureus, or tuberculosis. And I'll show you a picture. This is a fluctuant red lymph node at the angle of the mandible in a 1-year-old. Okay, All right, the right answer is D, Staph aureus, but if you picked A, I can understand that. This could certainly be group A strep. But in a 1-year-old, it's fluctuant. It's more likely to be Staph aureus displaying the odds. If it was a school-age child, it'd be more likely to be group A strep probably, okay? So the majority of pyogenic cervical adenitis, again, Staph aureus and group A strep, these are usually unilateral. Staph aureus is a little bit more indolent than group A strep, but is more likely to suppurate. And about 80% occur in the young age group, toddler age group. A history of a preceding URI is common, and about a quarter to a third become fluctuant and need to be surgically drained. We finally get to a question about otitis media. We've been here 3 days, and you guys haven't heard about probably one of the common things that you see every day. And this may be the only question all week about otitis media. So which of the following is a true statement about acute otitis in infants and children? High doses of amoxicillin are effective in treating most non-susceptible strains of strep pneumo. Clindamycin is an appropriate choice for initial empiric therapy. High dosages of amox are recommended to overcome resistance caused by beta-lactamase-producing organisms. The advantage of amox clavulanate over amox is improved activity against non-susceptible strep pneumo, or macrolide antibiotics are considered first-line agents. You have to read this very carefully. This is a tricky question. They generally don't try to trick you on the boards, but I put this in just to prove a couple of important points. Okay, so the right answer is A. Okay, so most of you chose C. So let's look at this. High dosages of amox are recommended to overcome resistance by not beta-lactamase. You can't overcome beta-lactamase by increasing the dose. Those are all or none. Either they produce beta-lactamase or not. If they do, no matter what dose of amox you use, it's not going to work. They are used to overcome strep pneumonia resistance, which is a totally different type of resistance, okay? It's penicillin binding proteins. So let's talk about this a little bit. So they're not going to ask you what the most common cause of otitis media today is, because it's a toss-up between H. flu and strep pneumo. So if you remember those two and you remember Moraxella, you'll be good. It appears that over the last decade or two, there's been an increase in H. influenza and a decrease in strep pneumo, but not every study has borne that out. So the rate of resistance with strep pneumo is about 30% overall, and about 15% are highly resistant, and 15% are intermediately resistant. Whereas H. flu, 50% resistance, and MCAT, almost all of it is resistant. However, the resistance to strep pneumo is altered penicillin binding protein, which can be overcome by using higher dosages of beta-lactams. whereas resistance to H. flu and MCAT is through beta-lactamase, which cannot be overcome. So for H. flu and Moraxella, you actually have to use a beta-lactamase stable agent. Amoxicillin will not work regardless. But with strep pneumo, amoxicillin high dose will overcome most resistance. And actually only those very highly resistant with MICs over 2, which are rare, that do not respond to high-dose amox. It's important to remember the risk factors for resistant pneumococcus, and those include child care attendance, recent antimicrobial therapy, and age less than 2 years. So why we still recommend amoxicillin as first-line agent is for those reasons. It is effective against susceptible as well as most resistant strains of pneumococcus when used at high dosage. It's safe, it's cheap, it tastes great, and it has a narrow spectrum. Remember also that strep pneumoniae is much less likely to resolve spontaneously, whereas H. flu and Moraxella, even without antibiotic treatment, those are likely to resolve, whereas with strep pneumo is the one that you need to treat with antibiotics. But because we don't know, you want to treat empirically, so if you start with high-dose amox, that should cover most strains of strep pneumo, and if that doesn't work, then you're likely dealing with a beta-lactamase producing bug like Moraxella or H. flu, and then you can go to a beta-lactamase stable agent such as amoxiclavulanate. Okay? All right. So a 1-month-old girl presents with a 1-week history of URI symptoms, severe cough, recurrent episodes of gagging, and post-tussive emesis. On further questioning, mom tells you the baby turns blue during the coughing and gagging episodes. Physical exam is normal except for conjunctival hemorrhage. The white count is a whopping 38,000 with 85%. The lab tells you these are small lymphocytes, and the platelet count is 670,000. But I'm not going to ask you what the diagnosis is. So of the following, the most likely additional feature to be present in this baby is that fever, eosinophilia, pneumonia, seizures, or hyponatremia. This is a tough question. So the baby has pertussis, right? So anytime you hear gagging, coughing, post-tussive emesis, a whopping white count, that's going to be pertussis. So the most likely concurrent thing would be C, pneumonia, okay? The fever is very uncommon with pertussis. Eosinophilia is not seen. Seizures can be there, but is less common than pneumonia. And hyponatremia is not a common feature with pertussis. So most infants, most young infants with bad pertussis, like this baby has, likely has pneumonia, okay? So a couple of words about pertussis. You're all familiar with the 3 classical stages. The catarrhal stage resembles a cold, and it may go unrecognized in young babies. The paroxysmal stage is where there's a repetitive cough, the classic whoop, the post-tussive emesis, choking, gagging, especially in young babies such as this one. So if you hear post-tussive emesis, gagging, you got to think pertussis. In between, these babies look fine. The convalescent stage can last weeks after and can be exacerbated by subsequent respiratory illnesses. Hey, again, the physical exam is usually normal. There may be some conjunctival hemorrhage and petechiae just from the coughing. Laboratory findings, a high white count is very common, and that correlates with the severity of disease. So the higher the white count, the more severe the infection. And we usually see this in the late catarrhal and paroxysmal stages. These are small T and B lymphocytes. They're not the atypical lymphocytes that we see with infectious mono. Thrombocytosis is common. Eosinophilia, again, is not common. And remember that fever is very uncommon with pertussis. In fact, if you do have a baby with pertussis who has a fever, that baby very likely has a secondary bacterial pneumonia, okay? But even without that, primary pneumonia is very common. This is the differential diagnosis. Adenovirus is the virus that is most likely to mimic pertussis. And these are the complications. And as you can see, young infants very likely have pneumonia, seizures much less likely, and there's a significant mortality rate in young infants. So pneumonia is very common in babies who have pertussis. So a 12-year-old boy presents with a 2-week history of fever, sore throat, anterior and posterior cervical lymphadenopathy, and splenomegaly. You suspect infectious mono. Which of these is true? The presence of atypical lymphocytes is specific for EBV. Heterophile positive mono occurs with EBV but not with CMV. Older children and adolescents are more often asymptomatic than younger children. Or the presence of antibodies against EBNA, or EBV nuclear antigen, is indicative of acute infection. Okay, so the right answer is B. Heterophile positive mono occurs with EBV but not with CMV, and I'll show you why D is not the right answer. So heterophile antibodies, again, EBV but not CMV, toxo, or HIV. Younger children are more likely to be asymptomatic. So remember, toddlers frequently are exposed to EBV and they are usually asymptomatic, or they may have a mild fever. They don't usually have the classic symptoms of sore throat, lymphadenopathy, whereas the adolescents do if that is their primary infection. So the monoslide test, which looked for heterophile antibody, remember that young children do not develop heterophile antibodies, so therefore this is not a reliable test in young children. These are the serologic tests that we do, and as you know, the viral capsid antibody, IgM, rises first and then comes down. IgG goes up around the same time, a little later, but stays positive. This is the early antigen, which is not very helpful. But EBNA does not become positive till several weeks after the infection. So a positive EBNA means that this is old disease, okay? So a positive EBNA is actually evidence that this is not an acute infection, okay? So remember that. And this is just the same thing in writing. So 17, question 17, which of the following is true regarding the complications of infectious mono? Severe thrombocytopenia occurs in about half the patients. Cranial nerve palsies and encephalitis are common neurologic complications. Corticosteroids are indicated for patients with neurologic or hematologic complications, or a clinically apparent hepatitis is evident in most patients. Okay, so the right answer is B, cranial nerve palsies and encephalitis. So severe thrombocytopenia occurs in a very small percentage of patients. Corticosteroid, the only indications for corticosteroids with mono is what? Airway obstruction. That is the only indication for using steroids for infectious mono. And then a clinically apparent hepatitis is very unlikely. A clinically inapparent hepatitis is very common, okay? So you gotta read that carefully. So again, mild thrombocytopenia, cranial nerve palsies and encephalitis are the most common complications, the most common neurologic complications of mono. And again, a subclinical hepatitis is very common. And again, airway obstruction from tonsillar hypertrophy is the only indication for steroids. And we really like to only use steroids for patients who need to be hospitalized for airway obstruction. All right, now we're going to look at some pictures and answer some questions. So the organism responsible for this infection is most likely to be recovered from, and I'll show you, sorry. So that's the rash, that's the infection. So where are you likely to recover the organism from this patient? All right, so this is staph scalded skin. This is the classic Nikolsky sign rash. So this is a toxin-mediated process, okay? Therefore, you are not gonna find the organism at the site of the skin. It is usually, these babies are usually colonized in the nasopharynx, okay? So the nasopharynx is the most common focus of infection. You can also find it in the umbilicus or the conjunctiva, but the important point about this is a toxin-mediated process. It's a phage 2 from Staph aureus, and we usually treat these babies with anti-staphylococcal therapy. They usually require intravenous antibiotics for at least a couple of days. So a 12-year-old child from Ohio is brought to the ED with a 6-hour history of fever and a rash. The rash has spread over the past 4 hours, according to mom. No history of travel. He's febrile to 39 and has this non-blanching rash on both extremities. And this has spread rapidly within the last 48 hours, or the last 4 hours. So what's the most appropriate initial antibiotic regimen for this boy? Nafcillin, clindamycin, doxycycline, cefotaxime, or no antibiotics because this is likely to be a virus. I'll go back to the history. So spread over 4 hours, and it's a non-blanching rash, which you can see here. So you got to think, what is this? Oh, God. So what's the first thing you think of with a non-blanching rash that has spread rapidly with high fever over 4 hours? It's not Rocky Mountain spotted fever. Yeah, that should be in the back of your mind, but that's not the thing that's going to kill this child. What's going to kill this child? Meningococcus, okay? So I try to give you every clue that I could that this is not Rocky Mountain spotted fever. Okay, so if you're going to tell me you're going to treat with both cefotaxime and doxy, that's fine. But you don't get that choice, and you're not going to get that choice on the board. So one antibiotic is going to be cefotaxime until you've ruled out meningococcus. Now, if you actually take all kids with fever and petechial rashes, viruses are the most common cause, especially the enteroviruses. Meningococcemia causes about 10% of these. You also have to think about other bacterial agents as well. And Rocky Mountain should always be in your differential. So if they give you a kid from North Carolina and the rash has been there, several hours, and the kid has a headache, myalgias, then you want to think about Rocky Mountain spotted fever, which we'll talk about on Friday. These are the poor prognostic factors for meningococcus: hypotension, a low white count, petechial lesions within 12 hours of presentation, especially if they're rapidly progressing, and the absence of meningitis actually is a poor prognostic factor because this is spreading rapidly and the child has meningococcemia before they've even had a chance to develop meningitis. All right, so show you this rash. So what's the most likely agent associated with that rash? Mycoplasma, measles, EBV, chlamydophilia, or strep pneumo? So what is this rash? I think Dr. Tamburo talked about this a little bit. This is erythema multiforme, and so mycoplasma, is the most likely. So a couple of words about erythema multiforme. Remember, this is the spectrum of erythema multiforme major, which is Stevens-Johnson, where at least one mucous membrane is involved. About a third of these are drug-induced, a third are idiopathic, and a third are infectious. And the two common infections that you need to remember are Mycoplasma pneumonia and herpes simplex. Okay? That's it. What's the most likely organism complicating this infection? And I'll give you the clue. This is X marks the spot. You want to look here, but you also want to look at the rest of the baby, because the baby has another rash other than this. So what's the most likely organism complicating this infection? Group A strep, H flu type B, strep pneumo, staph epi, or Pseudomonas. This is tough. All right, so most of you figured out this baby has chicken pox, and this is a cellulitis complicating chicken pox, so it's group A strep, okay? So group A strep and Staph aureus are most common. Group A strep tends to be very, very severe and used to account for major morbidity and mortality when we used to see a lot of chicken pox. These children also can have other complications such as pneumonia, encephalitis, hepatitis, myocarditis, and arthritis. Okay, this one's easy. So what's the most likely bug here? You can just shout it out. All right, that's Coxsackie hand, foot, and mouth. Very good. All right, which of the following about measles is true? Fever disappears before the onset of the rash. Complex spots appear simultaneously with the rash. The rash begins on the extremities. Patients are generally ill-appearing, or the lack of conjunctivitis in measles distinguishes this from Kawasaki. Okay, very good. So patients are generally ill. Fever does not disappear with the onset of the rash. Fever is usually present throughout the rash. Complex spots are usually gone after the first day of the rash. And obviously these kids all have conjunctivitis, and the rash begins on the head and spreads to the trunk. Okay, what is this? What's the most likely etiology? Staph scalded skin, strep scarlet fever, bullous impetigo, or staph toxic shock? This one's a little tough also. All right, very good. This is bullous impetigo. So this is localized. It's most common in the perianal area, but can be in the extremities as well. There's no Nikolsky sign here, and unlike staph scalded skin, the staph is recovered from the lesions because this is not a toxin-mediated process. All right, we're just going to shout these out. Which one of these on your right is associated with Reye's syndrome? Influenza. Okay, good. So influenza and varicella are associated with Reye's syndrome, which is an important cause of spontaneous peritonitis. Strep pneumonia. Okay, strep pneumonia and E. coli are the most common causes of spontaneous peritonitis. And you guys should all get this, which is an important cause of brain abscess in neonates. All right, you're going to get that one right on the boards for sure. And which one's associated with glomerulonephritis? All right, group A strep, post-strep. The animal who's most likely to harbor rabies is a bat, squirrel, dog, rat, or guinea pig. What do you think? We'll do this. All right, all of you got this right. This is a bat. So the following animals you should regard as rabid unless you know that a geographic area is free of rabies. Skunks, raccoons, bats, foxes, woodchucks, and carnivores all should be regarded as rabid unless you know otherwise. Whereas rodents such as squirrels, hamsters, guinea pigs, gerbils, chipmunks, anything small is almost never rabid. because if they get bit by a rabid animal, they're not going to survive, okay? Dogs, cats, and ferrets, they're possibly rabid, and you need to check with your local health authorities to actually help you decide about rabies prophylaxis. If they are healthy and available for 10-day observation with dogs, cats, and ferrets, then you only need to prophylax if they develop signs of rabies. So remember, local care, prompt and thorough local treatment, that's the most important thing you can do, as well as tetanus prophylaxis. We generally don't like to suture the wounds. And then you want to provide active immunization with rabies vaccine. It's a 4-dose series. And then you always want to give passive immunization with rabies immune globulin, which is given concomitantly with the first dose of vaccine unless they've been previously immunized. And you give as much as you can locally and the remainder intramuscularly. All right, I think this is the last or next to the last series. We can just shout these out. Which of these, scarlet fever, rheumatic fever, both or neither, causes migratory arthritis, erythema marginatum, and chorea? All right, that's rheumatic fever. You guys you've heard a lot about rheumatic fever, which is a toxin-mediated response to group A strep. That's scarlet fever, okay? That's not rheumatic fever. Rheumatic fever is an immunologic response, not a toxin-mediated. And which one gives you a strawberry tongue, sandpaper rash, and postia lines? That's scarlet fever. Okay, so I'm just going to show you a couple pictures of scarlet fever. Postia lines are areas of accentuation of erythema around the skin creases, most commonly found in the antecubital fossa. This is the strawberry tongue, and this is Postia's lines right here, areas of accentuations. This is the scarlatiniform sandpapery rash. Okay, very good. We're only about 9 minutes behind schedule. I apologize. All right, 3 down, 2 to go. Everybody have a wonderful evening. We'll see you tomorrow.